Hello and welcome to this GUSI anterior hip ultrasound video. In this clinical correlation series, we're going to first talk about the diagnostic anterior hip exam, focusing specifically on how to measure for a hip effusion. Then we'll spend the second part of the video talking about hip joint injection and aspiration techniques. This is Ryan Petering. Here's our agenda for the day. After reviewing some literature, we'll talk about the relevant hip anatomy on the anterior aspect. Then we'll talk about how to assess for an effusion in the hip joint. During the injection part, we'll talk about indications and techniques. We'll wrap up talking about pitfalls and summary of the hip anterior assessment and injection. In the literature, one of the most useful topics is the assessment of hip effusion. There's been several types of papers or studies that have looked at comparison of ultrasound with MRI. There's a whole other discussion we'll talk about in the injection section about comparing outcomes after hip injections. In this study, we highlight the word of bone capsule distance, and that's referred to as the BCD. A BCD greater than 0.7 centimeters was consistent with a hip effusion on both ultrasound and MRI, and these two modalities correlated well. As we talk about the approach to hip ultrasound, it's important to focus on the probe selection. For the majority of patients, the probe best suited for the hip is the curvilinear probe, which is shown here on the right side of the screen. When we look at the curvilinear probe, we see a wider field of view. Here we see from the femoral head all the way across many centimeters down the femur. The curvilinear probe has a deeper penetration and will sacrifice some clarity of image, but the deeper penetration and deeper field of depth is usually useful. On the left side of the screen, we see a linear probe, which has much greater muscle clarity. When we look at the superficial structures, here the sartorius muscle, comparing it to structures on this side, there is much greater detail. However, notice the narrowed scope of our field of view. Here the femoral head doesn't fully fit in the video or image, and we cut off the image just at the end of the joint capsule and lose all of this tissue seen on the curvilinear probe. So in general, use the curvilinear probe unless the habitus of the patient is very lean and you have a very small body frame that maybe a linear probe would be useful. When we review the anatomy, we'll discuss the major structures. I'll show you on the next slide several different approaches to obtaining images, but the structures will all be the same. Starting with the bones of the femur, specifically the femoral head and the femoral neck, the acetabulum as part of the bony pelvis, the joint capsule, the muscles, primarily the iliopsoas and rectus femoris, but we also see tensor fascia lata and sartorius. The main neurovascular bundle is located medially to the field of view, which we'll be using throughout this scan. There is an artery, the lateral femoral circumflex artery, which we'll comment on later in the discussion. So this slide is busy, but we'll go through it in detail because it really sets you up for success when doing assessments of the hip. On the right side of the screen, we'll highlight this green bar, which is indicating the probe placement on the body, on the anterior hip, representing an axial type view. We'll refer to this as a short axis view of the anterior hip and is illustrated in the green bundle. The iliopsoas is the primary structure we'll see, with the iliopsoas tendon being in the medial deep aspect. These green crescents represent the potential space of the iliopsoas bursa. The AIIS, which is the anterior inferior iliac spine, which is illustrated here or here on the X-ray, is the attachment of rectus femoris. The tensor fascia lata is the most lateral muscle, and the sartorius is the most superficial muscle. When we do an axial scan of the anterior hip, this yellow marker indicates the extent of the scanning zone. We want to go proximal to the AIIS, at least to here. You can go all the way to the ASIS, but there's less clinical pathology there. And we want to go distally beyond the hip joint capsule. Shifting your view to the left side of the screen, now we'll focus on the blue long axis, which is represented by this mark. Here we're going similarly, at least to the AIIS, to make sure we get high enough up to see the footprint of the rectus femoris muscle, which attaches on the AIIS. The deeper muscle is iliopsoas, and we'll see some views of the joint capsule. Last, the femoral neck view, which doesn't have a great anatomic correlation other than the linear representation of the femoral neck angle. This is the primary view we use for injections as well as assessing for diffusion. Let's start with the short axis view. Here's the structures as we reminded those on the previous slide. The probe is placed in an anterior view across the front of the hip. Let's look at this in real time. Here we see the iliopsoas tendon, which with wagging of the tail, we see its anisotropy. This is the iliopsoas muscle. Here is AIIS. And just on top of AIIS, we'll see the rectus femoris tendon. Once again, the neurovascular structures are medial, iliopsoas, sartorius is at the top of the screen. Here we see AIIS. The joint capsule is deep to the iliopsoas. Here's the femoral head. Here we see AIIS and the rectus femoris tendon just on top. So that's the axial or short axis view of the anterior hip. For the long axis view, we'll anchor the probe over the AIIS, which is just proximal to the joint. Here we see the joint, and the probe is just proximal on the left side of the screen. We'll look for linear bands of fibers running this direction, as seen in the diagram. The rectus femoris tendon at the insertion of AIIS is a difficult exam due to a curved nature of the two heads of the rectus. However, we can see here that the tendons are identifiable. This patient or case actually has some small calcifications shown here on AIIS, where the rectus femoris comes and attaches. Again, notice the deep hip joint just distal to the AIIS. Now for the femoral neck view. This is our primary working view for measuring for the bone capsule distance. Here the arrow is highlighting this. Here's the femoral head coming to the acetabulum, the joint capsule. The iliopsoas is the most predominant muscle on the front of the hip. The rectus femoris is visible distally, depending on how far down the joint you scan. Notice on the diagram, the iliopsoas muscle lies on top of the joint capsule, and the joint capsule comes several centimeters down the femoral neck, which is shown here. When making assessments of an effusion, we'll cover in a moment how to measure the capsule thickness or the bone capsule distance. When planning for an injection, it's important to find the lateral femoral circumflex artery, which is shown on the diagram here. This vessel is relatively small and isn't the primary femoral artery. However, it can be directly in the way of an approach with a needle. Here we see some still shots illustrating the linear view with a linear probe, As we look at this, we'll see the joint capsule highlighted on the right side of the screen with the dotted lines, femur, and the acetabulum. This is the femoral neck view. Here we see the artery on Doppler, which is a little more deep and would probably not be in the way of an injection, but still worth practice finding and identifying. Here we'll watch a video which shows a deeper hip joint on a curvilinear probe in the same femoral neck view. And here we see this vessel is relatively prominent. Given this is a small branch, it's highly individualized how large this branch will be. Some athletic or muscular patients, this vessel can be quite large. Other patients, you may not even be able to identify it. This slide shows the complexity of looking at the anterior hip based on pathology and habitus. On the right side of the screen, we'll see a lean patient with no pathology and a very clean femoral neck and head view with the joint capsule and the illustrations of measuring the capsule, iliopsoas, rectus, sartorius. On the left screen, we see a curvilinear probe on a patient with a larger habitus, with adipose tissue taking up the first several centimeters of the skin. The joint is very deep, and also there is significant arthritis in this hip. So the femoral neck is obscured or not at all normal appearing, as we see on the right side of the screen. This takes practice in seeing pathology with ultrasound on the anterior hip, as something like this may be disorienting to a viewer who doesn't see the femoral head, which is a nice, clearly identifiable viewpoint. So now let's focus our energy in making assessments of an effusion. As mentioned in the opening literature slide, the bone capsule distance, or femur to capsule distance, greater than 0.7 centimeters is our primary measurement. Another option in children or other patients would be to compare the affected side to the unaffected side. Here is an example of a relatively large effusion where we see a significant thickness increase in the capsule. This one measured just over 1 centimeter. And as a reference, here we have a normal capsule of less than 0.7 centimeters. So here almost double the thickness of a normal hip, consistent with an effusion. Here we see another effusion, this time with debris inside of the joint capsule. So here the bursa or capsule is distended, and instead of being in line with the femoral neck and curving along as we see in the normal view here, the effusion causes the capsule to bulge outward. This is a large effusion. And here we see a case of transient synovitis in a child. This illustrates that the thickness meets our criteria of 0.7 centimeters, so greater than 0.7 centimeters, but also comparing the left image, which is the affected hip, and we see this increased hypoechoic fluid collection within the hip joint, or the right side, which is the unaffected hip, which shows minimal black hypoechoic fluid in the joint and a clear difference in the capsular distension. Next, let's turn our attention into the joint injection and aspiration technique. In terms of literature for this, there's still many styles and philosophies related to hip injections. Many radiologists still prefer to use fluoroscopy when doing hip injections. Doing ultrasound-guided injections has been shown to be useful in many different arenas. One example here is highlighted by the use of diagnostic hip injections as a clinical tool. Given the complexities of making diagnostic assessments of hips, specifically things like labrums or articular cartilage damage, Using hip injections, sometimes with lidocaine only or often with other treatments such as steroids, the findings and outcomes after an injection, specifically the non-response to an injection, being a strong negative predictor of surgical outcomes, is of great value for a clinician. So when should we talk about doing this? First off would be for the treatment of hip conditions. This could be for arthritis of the hip or cartilage damage, labral pathology, and or hip impingement. The other option is for a diagnostic test. As mentioned in the previous slide, if there is confusing or redundant findings on imaging, such as back pathology as well as hip pathology, an injection into a hip joint is a useful technique to help localize where the pain may be coming from. So the primary view for doing an injection is the in-plane femoral neck view, which we talked about earlier, here illustrated by the red mark on the femoral neck. Here's the image we covered earlier, looking at the structures of the hip. The red arrow indicates our rough angle of injection. So here's our basic setup. The patient is prone. We have a draping with a sheet that allows the patient to not fully undress, but keeps good covering of the area we don't need to see with the injection. The probe is anchored with good skin contact, and we set up the needle coming from the distal side of the probe. If you've not watched it yet, the general injections procedures and techniques video is very useful to review, as it covers many basic injection discussion points. So now that we've got the setup for how to approach a hip injection, there are 5 steps that can be useful to confirm hip injection accuracy. The previous slides using diagnostic or therapeutic hip injections, it's critical to be sure that you're in the capsule. First, we watch the needle coming to the joint. Second, we visualize the tip actually in the capsule. Third, we feel the femur with the tip of the needle to ensure we're not backing out of the joint. We see the capsule thicken during the injection. And finally, if there is something such as a steroid in the injection, or even the lidocaine alone, we'll typically see some kind of a flash due to small air bubbles at the end of the injection. So first off, tracking the needle and visualizing the tip in the joint capsule. Here we see the needle coming through the tissue, but as we get distally, we don't see the needle here. This has to do with the placement of the needle and the correct finding of the needle as it travels to the deepest parts of the injection. Here we see the needle moving and entering. Here we see another with a linear probe where we actually see the tip and we see the capsular thickening. So even though we don't see the needle well all the way to the joint, we see the tip very clearly right here, and then we see the thickening of the capsule clearly representing that the needle is placed correctly in the joint space. Here's a video of a deep hip injection. The needle is coming in this plane, and here we're illustrating the particulate, which is this white injectant that fills the space as the needle injection occurs. Here we'll see an injection starting with the needle entering the skin on the right side of the screen. As the needle tracks towards the joint, we see the needle relatively well all the way to the joint capsule. Here we're looking to confirm the needle is in the capsule. As the injection starts to occur, we're looking to see thickening of the capsule. If there's any doubt about whether there is thickening of the capsule, sometimes the needle can be redirected and placed in a different spot in the joint capsule. But here we see the tip of the needle well in the capsule as the injection is being performed. Well, obviously we cannot demonstrate with the video the feel of the femur, but primarily it's a good reminder to make sure the needle is able to touch the femur. Sometimes as the injection begins, the needle pressure will cause the needle to back up a little bit and you'll come out of the capsule. That's why gently touching the femur is a reminder you're in the right space. So let's watch this video that has all of the pieces put together. We're going to look for the needle to enter on the right side of the screen. Here with a curvilinear probe in a femoral neck view injection, we watch the tip of the needle and the travel path. Here we see the needle in the joint capsule. We see the particulate flash as well as the thickening of the capsule. The injectant runs along the femoral neck, confirming we're intra-articular. The capsule enlarges, creating an iatrogenic effusion. And now we see the injectant and the particulate all in the joint capsule. This is the ideal set of findings we hope to see. Here we'll see another example as the needle comes in. Here, the needle is clarified by corrections of the probe. We're aiming for the femoral neck. I see the needle tip in the capsule. As the injection begins, we see the particulate matter here in the injectant. And then finally, we see the capsule thickening. There isn't an ideal location on the femoral neck to inject. Anywhere from the femoral head down to the neck is adequate. There is articular cartilage further proximally, so be careful there. And then lastly, we want to make sure we don't go too far distally where we could miss the capsule. So one finding in deep injections that is a common source of error is that the proximal part of the needle will be seen well, but the distal part is not seen well. This has to do with losing the needle under the probe due to the depth of the injection. Here's another example with a curvilinear probe where we see the needle well, and then we lose the needle here. This requires correction of the probe angle that we'll reference to as pivoting. So here is the ideal outcome where the needle is perfectly under the probe. These left-sided images illustrate this, where maybe the proximal part of the probe is good, but the distal part is not. So we're going to pivot the probe. This part of the probe stays still. The distal probe rotates to align with the needle. Let's watch that one more time. This is one of the most critical techniques for cleaning up the image during a deep injection of any kind, but the hip joint being the classic example. So when I see error, I don't want to move the whole probe. I only want to move the distal part of the probe to match the needle placement. If I move the entire probe, I'll lose the anchor point that I have that was correct to begin with. A couple of other clarifying techniques or tips. First off is the needle injection angle. So when we talked in other slide sets about anisotropy, the steeper the needle angle, the more anisotropy will develop. Sometimes based on the patient's habitus, we may be able to come with a more flat needle injection angle. So compare the needle angle here to the needle angle here. This change in needle angle will have a big difference on the outcome related to anisotropy. The image on the left is preferred. However, one needs to take care in making sure they have enough needle length or that the patient's habitus doesn't require going really close to the probe. Next is the toe-in technique. So here we see on the right side a more standard probe placement with the probe being perpendicular to the body. The needle is coming at a flatter angle. If we need to bring the needles closer to the probe and at a steeper angle, notice that the probe is now toed in. So on this side, the skin is compressed or pushed down with the probe so that the probe tilts away from the needle. This will change the orientation of the beam to the needle in a preferential way. The last technique relates to fanning or pivoting the distal part of the probe. This will change the view of the femoral neck. Every patient has a slightly different appearance. Some you'll prefer to have the probe more midline, others a little more lateral. The only caution here is be reminded that the femoral arteries and veins live here, so we don't want to come more than midline. So common pitfalls related to hip injections. First off, draping of the patient. It's a difficult task to drape a patient well and make sure you have adequate exposure. It's useful to be thoughtful of this as far as keeping a patient covered and protected, but getting the exposure you need to set up the injection properly. Due to the depth of the hip joint, it can be difficult to maintain good needle visualization, and as we review, there are several steps you can take to prevent losing that needle. And then finally, if you're doing a diagnostic injection or even a clinical therapeutic injection, it's critical to be accurate and make sure that you're in the joint. We reviewed 5 steps that can help you avoid this common pitfall. So in summary, the diagnostic anterior hip ultrasound is useful, specifically for the clinical question of is there an effusion. The ultrasound-guided hip injections can be useful for both diagnostic and therapeutic applications. And then finally, use the 5 methods we discussed to confirm the correct intra-articular emplacement of a needle. That includes tracking the needle to the joint, visualizing the tip in the capsule, feeling the femur with the needle, measuring or noticing the thickening of the capsule, and finally the flash of the end of the injection. Thank you for watching this video.